Thank you very much for the invite. As Prof. Adam has said, I have been tasked by WITS to head the surgical side of treating obesity. And I mean, as most speakers have already mentioned, a lot of issues surrounding obesity. I mean, as you can see that in this slide, South Africa is really now getting par to most of the world, Europe, US, in terms of getting obesity. This slide has already been shown by one of the presenters previously. I mean, we're looking at people getting overweight up to 70% in the female population, which is really a scary thing. The next slide, I just want to show you here that in terms of where we are in sub-Saharan Africa, we actually are the highest in terms of the obesity statistics. But I think what is more scarier is the fact that we are now also starting to see obesity and in the pediatric population. These are some of the complications that I'm sure that most people would know, that we've already spoken about cardiovascular issues and all the issues that you've spoken about. I think in terms of how do we manage this, the first part of it is community-based. We talk about awareness and prevention. It's difficult in terms of awareness because at the moment, in terms of awareness, we're not really getting a lot of awareness. Growing up, we were told that if you have a big tummy, then it shows that you are a husband who can provide for the family, and that has stayed with a lot of us for a very long time. And it's now come to, you know, it's quite difficult to now change the perception that people need to look at weight more carefully than that. And then there's what we are dealing with as individuals from an individual-based point of view, where there's a few things that you know, people have spoken about: diet, physical exercise, medical management, endoscopic management. And where I come is a surgical management, and I will demonstrate how the surgical part of it comes into this, and why it is effective actually to treat patients surgically. But what I want to emphasize more before I talk about the surgery is that obesity is not about surgery. Obesity is not about medical treatment. It's not about that. It's all about you know, the MDT, where we need to sit together and decide that this is how we need to deal with obesity as health practitioners, because one area does not completely eliminate obesity. And if we put things together where decisions are made, then it makes things much easier. Now, how does it work? There's a 4 ways in which we've been looking at the surgery for. So mostly people will know about restriction, malabsorption, and I had obviously some of the speakers have already talking about the enteroencephalic endocrine axis and the enteroinsular axis. The restriction and malabsorption is straightforward. When I'm talking about the enteroinsular endocrine axis, people have already spoken about ghrelin, which is a hunger hormone. So there's a hunger appetite stimulant, and we have a hunger appetite suppressant. Now, if you are able to balance those hormonal changes, then you're able to manage the weight. And I think that with CMJAH at the moment, we are able to do that, and this is why CMJAH is becoming effective. Now, what is ghrelin? Ghrelin is a hormone that is produced by the PD-1 cells, which are found in the fundus of the stomach. Now, I'll show you a graph. So these are some of the functions of ghrelin, which I think that they've already spoken about before. But so what happens with a ghrelin is that your ghrelin levels go up before you eat. And after you eat, the ghrelin levels come down. And they come down because the ghrelin then inhibits the neuropeptide Y in the hypothalamus, which then says this person is now full, and then they must stop, they can stop eating. Now, what I want you to see here is what is interesting is that if you look at the two graphs of ghrelin graphs, where this is a lean individual and this is an obese individual. The lean individual has basal higher ghrelin levels than the obese individuals. What that means is that if you are lean, you are constantly in a state of hunger. Which is why it is easy for a lean person to gain weight. That is physiological. For someone who is obese, your basal levels they go slightly lower, but the problem is that once you reach those levels of obesity, it becomes difficult to regulate your own physiology in terms of the ghrelin levels, and that affects how you're going to eat. This here is another graph, the same thing showing ghrelin levels. So this is a ghrelin levels of an individual who, before they decided to lose weight with diet and exercise. This is how the ghrelin levels looked like. And once they decided to lose weight, then the ghrelin levels went even higher. So what that means is that once you can exercise as much as you want, you can diet as much as you want, but unfortunately, physiologically, the body is in a state that wants you to eat all the time. You're sort of in a negative balance. So your ghrelin levels stay high, and this is where the problem is. And if you see here, this is a patient who has had, this is a sleeve gastrectomy, and this is a bypass, Roux-en-Y gastric bypass, even though it's a poorly made Roux-en-Y gastric bypass, but it will show the point I'm to make here. So ghrelin is produced here in the fundus of the stomach. Okay, so now if you do, so as I said, these are unfortunately poorly made diagrams. So when you do a sleeve, you actually should be coming here so that all this part is not part of the stomach anymore. And when you do your bypass, your pouch becomes even much smaller so that this part of the stomach is not involved in any of the, so you have to exclude the entire fundus so that the PD-1 cells are excluded, and the levels, they go significantly lower. If you look at this is a patient who has had a gastric bypass, and this is the nocturnal values of ghrelin levels. So if you've had a gastric bypass, essentially, even before, you are in a state of not being hungry at all, as compared to these are ghrelin levels of patients with a normal weight, and then these were the control. So even before doing anything, just by cutting the fundus, you already excluding the PD-1 cells, and you're already making the patient less hungry, and that really improves the patients in terms of the eating. Now, the second physiological mechanism that has already been spoken about again is the ileal feedback mechanism. So the peptide YY is secreted in the L cells, which are found in the small intestine and the colon, and most of them are found in the terminal ileum and the colon. So how this works is the peptide YY, once the food reaches the terminal ileum and the colon, the peptide YY then increases, and then it then inhibits the neuropeptide Y. When it does that, then the patient obviously stops feeding because of that mechanism. Now, how does that help us? This is the slide. So what happens is, now, if you've had, say, a sleeve gastrectomy or even a bypass, you've made a stomach smaller and have excluded the PD1 cells. Therefore, the patient is less hungry and the patient will eat less. And by bypassing a limb lower down into the jejunum, you're making the food move to the ileum and the colon quicker. And when that happens, your PYY, you get to the cells that produce the PYY quicker. And when that happens, you stop the eating quicker. So in other words, with the two mechanisms, you just by doing a single operation, you've affected two mechanisms where you stop the patient from being hungry. And secondly, you've made the patient to stop eating quicker. And that is something that is not many people really think about, because most of the time we think about restriction. But this is and it's not only with a bypass. For instance, in a sleeve, you might not be bypassing a limb, but because you have a quick transit to the terminal ileum, because the stomach is now a tubular structure which does not store any food. Therefore, whatever you eat has a quick transit into the small intestine and into the terminal ileum and the colon. That then stimulates your L cells, and then your PYY is produced, and that gives a negative feedback to your neuropeptide, which are those are very effective mechanisms. So now this is this was a study done in 2006 looking at the PYY levels of patients, different patients that have had a gastric bypass and patients who obese and the controls. Now, if you look at this, you can see obese patients have this level of PYY, and lean patients have this level of PYY. But patients who have had a gastric bypass, your level of PYY goes very high after a meal. So 30 minutes after a meal, your levels of a PYY, in fact, they already start coming up immediately. You start eating and they reach that level, and you stop eating immediately and you don't want to eat. So that is a very effective mechanisms of controlling the enteroaxillary axis. Again, a few people have already spoken about, and this is controlled by the GIP and the GLP-1, which are GIP is producing the K cells in the duodenum, and it functions with the regulation of the beta cells, which obviously deal with the insulin and glucose control. Now, this contributes a lot to what we call the foregut hypothesis. So the foregut hypothesis, what the foregut hypothesis is, once you are able to bypass the foregut, you're excluding the cells, the K cells that then unfortunately are reverse incretins that are going to be more diabetogenic. GLP-1 is producing the L cells, which are in the terminal ileum and colon. Now, what this is a significant mechanism in terms of glucose control. So as I've mentioned before, that by doing a bypass, you have bypassed the PD-1 cells. You have also made the food come quicker to the terminal ileum in the colon, which then exposes the food into the K cells, which produces the peptide Y. The L cells, those ones, they respond to the glucose, and food coming into the L cells, it then produces your glucagon-like peptide, which then increases insulin sensitivity of the pancreatic cells and beta cells, which is also quite a mechanism. So these are the four mechanisms. This is just a schematic diagram to show that. But these are the simple physiological, well, maybe not simple for everyone, but these are physiological phenomena that make CMJAH even more effective. It's unlike your exercise, which doesn't affect any of the physiology, your diet, which doesn't affect any of the physiology. We have drugs now which are directly looking at the physiology, but unfortunately, even with the drugs themselves, they will look at specific, it's a single drug which looks at a specific mechanism. And nowadays, they're also talking about, combination drugs, which we will see with time. And hopefully that will come to some form of resolution to this. Now, when you treating the patient, there's two goals of treatment. The first one is weight loss, and the second one is a treatment of comorbidities. And everyone would know that with a diabetes mellitus, it's already it's been documented vastly, but there are other areas which you treat with the CMJAH, obstructive sleep apnea, hypertension, hypothyroidism, and hepatosteatosis also. So there's sexual dysfunction. There's a whole lot of things that you can treat with it. Now, I'm going to show you some of the procedures that we do. This is a sleeve gastrectomy. For those who don't really understand, you don't have to read through everything there. So what this does, this is a sleeve gastrectomy, which when you eat, we cut the stomach we tubulate the stomach, and by tubulating the stomach, the food transit is quicker. You eat a smaller amount of food. Then the transit is quicker, as I've already mentioned. This is a quick procedure. Its advantages is that it's a procedure that does not have anastomosis, and therefore, in terms of the leak rates, you really have a lower leak rates. And this is one procedure where a lot of general surgeons who have now learned some of the bariatric procedures would do this procedure. The problem with that is that if you do a lot of patients with obesity, if you're just treating them based on your knowledge of knowing how to do a sleeve gastrectomy, it becomes a problem when the patients do come back to you with weight gain. And if they gain weight, they gain weight because the diameter of the stomach enlarges. And the only way you can make sure that the diameter of the stomach does not enlarge is by following up patients. So when we operate on patients and you're not following up patients, that becomes a problem, where the MDT becomes more important, because when you follow up patients, you know exactly how much diet the patients are getting, how much volume is going into that stomach. And because if you don't know how much volume into the stomach does distend. And the other thing also is a lot of the sleeve gastrectomies that have been reviewed, most of them have been reviewed because of the poor technique. And unfortunately, at the moment, we don't have people who are training the surgeons here in South Africa who are training us how to do these procedures properly. So, people learn how to do these procedures, and then they don't learn how to do them properly, and then patients come back with a weight regain. This is another restrictive procedure, which is it's a band. This procedure is not done. There are people who still do it, but all the studies have shown that this procedure should never be done because of too many complications. So I'm just showing it as just to show you. Malabsorptive procedures. There's been a lot of malabsorptive procedures that were done before. The jejuno-ileal bypass was a procedure which was done years ago, which has been stopped now. And the reason it's been stopped is that it used to cause a lot of weight loss, and it was causing a lot of morbidity. So, people have now moved to things like your pancreatic diversions, your duodenal switch, your sleeve DJPs. The one procedure that is now coming up in the entire world to be one of the biggest procedures that are going to come on is the one anastomosis gastric bypass, which was previously known as the omega loop bypass. The side bypass is also coming up. But the point is, at the end of the day, bypasses, and these are all malabsorptive procedures which work with the same physiological mechanism that I explained before. This is an example of a sleeve DJP. So sleeve with a duodenojejunal bypass. This is a procedure that you might not really understand very well, but if you are in the surgical unit, this is some of the procedures we teach in terms of surgical techniques. Combined procedures, the one procedure which is very common nowadays is a Roux-en-Y gastric bypass. In fact, not nowadays, it's the gold standard procedure that we now compare all the other procedures with. This is the Roux-en-Y gastric bypass, which is the pouch. So this is the stomach. So what we do is we take out the stomach, we exclude all the PD-1 cells. We are left with only a small pouch of the stomach, which it's supposed to be about only 30 mils. So at the beginning, the patient will only be able to tolerate 30 mils. And from 30 mils to get to that, it will take years and years and years. And that is why this procedure becomes more effective in terms of making patients lose weight and also with weight regain. So this is a small stomach, and then you bypassing it to the alimentary limb, and the BP limb, below pancreatic limb, and the alimentary limb. What has come up in the years is that one can be able to vary the limbs, and by varying the limbs, one is able to bypass a bigger length. Where if you bypass a bigger length, then you get more effects in terms of the weight loss. But what that does do sometimes is give a lot of complications when it comes to electrolyte nutritional deficiencies. But even with that, there are measures which are now there are measures which are now on the fore, which is exactly why I said before that if you are in an MDT, you know that when you do have such complications, there are ways of preventing those complications even before you start doing the surgery. Okay, so what about the complications? Again, as I said, it's surgery. Surgery can have complications, and you need to think about those things. Bleeding, most of the bleeding happens intraoperatively. We know that for people who do the procedures, we know that if a patient is bleeding, to prevent that is by oversewing the stapler. So the people who are routinely oversew the staple line, they don't get bleeding. The people who don't routinely, because it's not 100, is not you can choose to oversew the stapler or not. So the people who do not oversew the stapler, if you see the bleeding, then you have to oversew the stapler there and then. The gastric leaks, again, the gastric leak, it hasn't been a much of a problem lately. Where it has been a problem is in sleeve gastrectomies, if they're not done properly. And they leak, when they leak because the stomach is a high pressure system, because it's now a tubular structure with a pylorus present. If the pylorus is present, it delays the food. And if the patient is eating and you've made your staple line, your corner of the staple line incorrectly by the fundus, then patients, that's where they leak. Again, if you do get that leak, it's not difficult to control, because you can put a stent on it. Reflux, patients that do have reflux, you do not do a sleeve gastrectomy, because sleeve gastrectomy is the only procedure that will make the patients to have a reflux. Gastric remnant distension, that even if you do get that, it does not contribute to the weight regain. Stomach stenosis, that again is prevented by making your anastomosis to be 2 centimeters, or between 2 and 2.5 centimeters. If you do it smaller than that, then you will have a stenosis. Again, in terms of your surgical techniques, if you're using a linear stapler, you are unlikely to get a stomach stenosis, unlike if you're using a circular stapler, which you may get a stomach stenosis. But we know that most of the surgeons nowadays, no one uses the circular stapler. The circular stapler, it's for surgeons who are not happy yet with doing anastomosis, it's easier to do with less leaks, but the problem is the stenosis. Marginal ulcers, again, if you look at your procedures, marginal ulcers, you don't really get them in gastric, in Roux-en-Y bypass. You do get them in OAGB, which is one anastomosis gastric bypass. And the reason for getting marginal ulcers there is because when you do it, you leave a little bit bigger stomach than the Roux-en-Y gastric bypass. Cholelithiasis is something that it's a complication not of surgery, it's a complication of weight loss, which can happen with anyone who loses or gains weight. Hernias, at the moment, hernias, there's 3 places where you can get hernias, which is the mesenteric defect, which is the Peterson's space, or the port sites. Now, to prevent those the hernias is obviously the procedure, you make sure that your mesenteric defect is closed properly, and your Peterson space is closed properly, and also your port sites, you have to close them properly. I'm not going to go through, but what I'm trying to get to here is that when people are talking about the complications of surgery, yes, there are complications, but we have found ways of dealing with this, the complications. Now, there is a here where it says failure to lose weight. A small percentage of patients may, and this it's not only for people who have not done a lot of cases. It's also internationally, there are patients who will not lose the weight. And so far, the percentage for those people is only about 2%, and we haven't seen anything much more than that. But then the question is, people not lose weight if they've had the surgery. And I think one of the things, this is a study showing, and this looks at basically the diabetes. So if you look here at this study, which is maybe something that everyone must take home. Now, people, and I'm going to just, okay, so people who are over 60, so older age, they respond less to the bypass. Okay. Now, if you are less than 40, they respond much better to in terms of their the weight loss, in terms of the bypass. So they lose more weight than the patients who are older. All right. HbA1c, the most optimal HbA1c is between 6.5 and 8.9. The patients who have an HbA1c of more than 9%, the response rate is about 41%. Now, it is a good response in a way, but it's not the most optimal. Okay. This did not have a significant p-value. Patients who were treated with insulin, they responded, they did not respond best. So once you are on insulin, you are at a stage where you're probably already late. Now, in terms of the BMI, who responds better, this study showed for the patients that had a BMI of more than 42, they responded the best. But if you look at the 62% response rate for patients who have a BMI of 35 and above, so this also correlated very well. Now, the other thing is the C-peptide. The C-peptide is an assay which I have not really seen it being used much here in the country, but overseas they use it all the time to see the patients who respond better. Now, if you look at it, if you have a higher C-peptide, it means your pancreatic function is still very much functional. So when you do have the surgery at that time, your response is much, much better. Okay. They look at also looked at the duration of your diabetes. Now, the patients who were diabetic for more than 8 years, look at the response, 25%. Patients who were diabetic for less than 1 year, the response was good, 93%. So what is this saying? What this is saying is that when you are referring patients, patients need not be referred because all the other measures are failing, but you need to have a structure of referring patients that makes it easier to not get patients when it's already late, and you can get patients that may not respond to the surgery. This is just a study comparing sleeve gastrectomy, Roux-en-Y gastric bypass, one anastomosis gastric bypass. So here, what I just wanted to show was after 5 years, in terms of how many people regain weight, and there's really not much in terms of weight regain. So for the sleeve gastrectomies, there was about 18, Roux-en-Y gastric bypass 10, OHGP about 1.98. So there's not, with other measures, the weight regain after 5 years is a lot. But when they looked at the patients who regained the weight, and they looked back as to why did they gain weight, and the findings were that people regain weight because they did not follow the program. And someone earlier on, I forgot who said, but I think it was Fezana, said earlier on that obesity is a chronic problem, and it's something that needs chronic treatment. So you are not going to operate on a patient and then leave the patient and following them up, because you need to know exactly if they're sticking to the diet, and you need to know whether the procedure that they're having is holding them well, if you was to say that. Now, what we don't know at the moment is in terms of the other diseases. So because, as I said, there is that a small percentage of patients that don't respond to the surgery. And we don't know, is it a chronic, those with a chronic kidney disease? And there has been a few studies that looked at patients that were operated on for bariatric surgery that had chronic kidney disease. And in those cases, it was found that the bariatric surgery was not the best. The response rate was about between 20 and 30%, which was not great. There are new studies looking at that, which maybe there will be an improvement. Older age, again, we, do they respond? Do they not? We don't really know much. Pediatric population is only now coming up. HIV, we in South Africa have a lot of HIV, and in fact in Africa have a lot of HIV, but unfortunately in terms of the people that are at the moment contributing towards the registry, it's only in the North Africa, the MENAC chapter, which is Middle East and North Africa, but the rest of us are not putting any, are not registering any of the cases. There are people who are doing a lot of cases in private, but no one is putting any patients into the register. So at the moment, this is something that we need to look at, whether patients with HIV, do they need bariatric surgery? Would they respond? Would they not? At the moment, we don't have the answers for that. And other areas like liver disease and people with eating disorders, because people with eating disorders, as much as you might have done the surgery, if someone has an eating disorder, they are not likely to follow the program. And these are just the indications for bariatric surgery. I think they've already been explained before. I think in terms of my conclusion, I would just say that we need not be looking at just one thing, looking at the surgery or looking at whatever we'd be looking at as a single modality for treatment of obesity. We should be looking at it globally, and we need to start referring patients at the appropriate times. Thank you.